Perfect. Can you see my screen now? Mhm. Okay. Now, let's continue our discussion on how to assessing decision-making capacity. So the decision-making capacity is for low-risk medical decisions, like venipuncture for routine laboratory studies, can be assumed, and if the patient demonstrate understanding on the conversation. Like a patient coming to the ER now complaining of fever, uh, Dr. Star, please admit the patient when they join the waiting room or cancel the waiting room if possible. Okay. So if a patient is coming to the emergency department with um, something simple like fever, and I need to give them like a venipuncture for fever treatment. If they are understanding me, I'm not gonna bring a piece of paper and tell them like you need to assign a consent for me. So for low risk medical decision or like a very simple drug, I can assume it without a consent if the patient is understanding during a conversation. Okay, I'm gonna give you an injection now. Okay, doc? It's okay. So what is the indication? Informed consent is required prior to blood transfusion or invasive procedure if the patient is going to have a hernia. So informed consent is a must. Incapacity is always suspected. Okay, like if a patient is a minor but they are serving in the military and they are having a very invasive procedure, we're gonna do it to you. Okay, do it. Do. I cannot assume like they are having the capacity. I need to bring a sheet of paper and tell them everything related to this procedure and what we're gonna do, what are the risks, to make everything clear. Okay. Prior to assessments, address low health literacy and communicating barriers like hearing aids or medical interpreter. If the patient is speaking Spanish or they are having hearing aids, I need to confirm that I have a medical interpreter on the side, or they are hearing me, or their hearing aids are working properly. Treat reversible causes of incapacity like intoxication and delirium. Okay, if the patient is in severe alcoholic intoxication right now, I need to treat it first prior to assessing their decision-making capacity. Same concept for mental illness if they are in uncontrolled mania or anything. Consider cultural context of the decision and its impact on patient values. For example, for Jehovah's Witness who decline products, I need to consider it on the back of my mind and make informed consent before I even ask them. If they rejected it and we are Jehovah's Witness and we don't need blood products, okay, I need to respect this. Okay. Directed interview. There are four required components that I said before: a choice, understanding, appreciation, and reasoning. Again, choice, understanding, appreciation, and reasoning. What is the choice? What decision have you come to? Okay, we need to give you XYZ drug. Okay, understanding in your own words. Can you describe the risks and benefits of the available options? Like if I told him everything, now I need them to repeat in your own words, what is the risks and benefits of the available options? Okay. So if they are understanding everything, they're gonna tell me, okay, we have option one, option two, option three, and this is associated with one, and this is the best option for me. Okay. Appreciation. I'm gonna ask them two questions. Question number one, how would you describe your current health situation? Okay. I'm very sick, moderately sick, and stuff like this. Do you think you would benefit from some form of medical intervention? Do you feel like you need it right now? And the reasoning. How did you come to your decision? Okay. So this is like a sharing decision capacity. I'm telling them we have one, two, three. And do you think your current health needs to make this intervention. Yes, I'm very sick and I'm having that big hernia and we need to remove it later. And if we didn't remove it, it may be at a risk of strangulation and bowel necrosis. So yes, doctor, I need to make this operation. Okay. Then if they are okay with me in a choice, understanding, appreciation, and reasoning, I can consider they are having the decision-making capacity. Further assessment is needed if I am uncertain after this interview. Like I can use a formal standardized assessment tool, like a aid to capacity evaluation, MacArthur competence assessment tool for treatment. You can Google it at any time. You're gonna find like an assessment tool, and you're gonna like check what the patient have and what he doesn't. Second thing is repeat the assessment to evaluate for changes in capacity. Okay, if the patient is having alcoholic intoxication and I mistakenly assessed it and he didn't have the decision-making capacity, now I can treat him and then repeat my assessment to determine if they are having the decision-making capacity or not. But they need the decision-making capacity to make the informed consent. Okay? Identify and treat reversible causes of incapacity like delirium, infection, intoxication, or medication. And pay attention to medication because this is very important. Sometimes you miss it. Sometimes you check for delirium, infection, intoxication. But always for the USMLE exams, pay attention to medications. If a patient is coming like with 2 days history, complaining of some symptoms, and there is an option that is telling you review of the patient medication history or ask them what medications are they taking, it is usually will be the answer. Do not exclude it unless you're very sure about your second answer, okay? For assessing the capacity. Do not mistakenly pseudo capacity in lack of understanding due to insufficient patient counseling and or use of jargon or a decision against medical advice of lacking a decision-making capacity. Okay, I need to counsel the patient and tell them everything. Okay, we wanted to do for you like a hernia operation. Okay, I don't want it. This is not the typical assessment of decision-making capacity. This is insufficient patient counseling. I I need to tell them why you need to do that, what is the condition that you're having, what is the risk is, and everything. Okay? This is gonna take us to the shared decision making. Like me and the patient, we are going to talk together to see what is best for them. We are sharing the decision making capacity. We are working together to make the best healthcare decision. They're gonna understand and they're gonna agree, and this is gonna establish the physician-patient relationship. So the process should strike a balance between the patient's preference and values and the evidence-based information on the risks and expected outcome and the clinician's experience. A patient is coming to lose weight. Okay, what is his BMI? He wants to do the operation and his BMI on like 25. So it is not indicated to do a surgery now unless he's having a severe diabetes mellitus type 1 or some complications like metabolic syndrome. So I can tell him other options to lose weight and like we arrive to a decision together. Okay. As I told you, it is just we are talking together. So we are not going to talk together in emergency situation. So the indication of third decision-making capacity is usually non-emergent situation. Because if the patient is in emergent situation and is coming with motor vehicle accident, I'm not gonna tell them, hey, do you think you need mechanical intubation right now? It won't be fun. In which there is a clinical equipoise. A situation, what is clinical equipoise? It is a situation in which the benefits and risks of two or more medical interventions are thought to be generally equivalent. You have this option and you have this option. What do you think is better for you? Okay, and this option like this be like they are equal, but this one is cheap and this patient is like doesn't have the financial capacity to buy this expensive drug, so this is gonna be better for him even if they are equal. So the goals is the patient empowerment by considering their values, cultural beliefs and preferences when making a medical decision. And also, it is going to lead to a better or improved patient satisfaction and buy-in, like medication non-adherence. They are convinced. uh, okay, thank you. They are convinced that they are taking a beneficial drugs and this is the right medication for them. So this is gonna fix a lot of stuff, okay? Because if the patient is not convinced with what you are saying, and they feel like this medication is not gonna help, there is a very high risk that this patient may not adhere to taking their medications. Okay. We have a three-step model for shared decision making: choice talk, option talk, and decision talk. The first thing is a choice talk. This is an introductory discussion in which the patient is informed that there are choices available and that they can be involved in decision-making processes. Like I need to invite the patient to participate in decision-making capacity, the decision-making process. Like we are not separate. I'm gonna discuss with the patient. Um, I'm not gonna like write you have this disease and we're gonna give this. No, you have this and we're gonna like make a choice talk. Okay. And for your disease, there are different ways to approach your disease. Okay. Like I'm explaining to him the choices and then assess the patient current knowledge and their understanding. Some patient is having like ulcerative colitis. What is your understanding or knowledge about ulcerative colitis? They may have a relative who got this disease before. They may have suspected it or read in Google, which I do not recommend. Or like they knew something or have seen another physician before and told them that you have UC and this disease is 1, 2, 3. I need to know to what extent they know about the knowledge and understanding. This is very common question, and it is gonna be usually they are asking what you're going to say to the patient, and the answer will be, what do you say, what do you know about ulcerative colitis, or what do you know about your current disease? Okay, this is for the choice talk. For the second one, which is option talk, it is a discussion about all the available options. Discuss the risks and benefits of the available options using the decision aids if available. What is the decision aid? Like brochures, videos, online programs, decision tables. Okay, decisions patient enhances the patient's ability to make informed choices. If they do not understand more information about every option that I listed to them, then I'm gonna ask the patient about their preferences. What do you think? Okay. Then I'm gonna conclude by checking the patient understanding of all options, not only of the options that they picked, because they may pick the options that they already know, but they are not familiar with the other options. Okay. Then the last thing is pick the final decision. I'm gonna discuss with the patient either he makes a decision based on their preference or defers the decision. Ask the patient to confirm or defer this decision. Do you really want this? Okay. Then I'm gonna review the decision of the teach back method. The teach back method is when a technique to verify patients' understanding of the health information they have been given. Patients demonstrate their understanding of information by teaching it back to the clinician. And this is very important one that we really use in clinical practice. You have ulcerative colitis, and we're gonna give you aminosalicylate, ASA enema, for example. Do you know what I told you? Then, as I teach it the patient, I want the patient to teach me. Okay? If a patient defers a decision, revisit the decision talk in subsequent conversation. Like, I think you need to stop smoking. Okay? No, I'm not gonna take the decision of stopping smoking right now. Okay, enough is enough. I'm gonna discuss it in further conversation. Okay? If a patient is like incapable or like we have something that is not the typical situation for making their decision, I can make a surrogate decision making, like an alternative person, like their parents, his wife, or anyone in the family. Uh, accordingly, according to hierarchies that we're gonna talk about to take their decision. So what is a surrogate decision making? It is a model in which another person makes a treatment decision for the patients because they lack the decision making capacity and or legal competence. So general, a surrogate may be appointed by the patient, like medical power of attorney. Who is the medical power of attorney? This is a legal document in which a patient grants authority to a surrogate to make medical or health care decisions on behalf of the patient. Okay? In the event he or she loses decision-making capacity or competence. This is advanced directive. Okay? Let's say a patient is diagnosed with severe disease and they may become like ALS patient and they may become incapacitated or in like hypertrophic cardiomyopathy and they may lose conscious at any time and they have the medical power of attorney and he listed that this person gonna take his decision and this patient become incapacitated or they made something and they came to the emergency department and they need to be intubated or they are dead and we need to know if he is DNR, do not resuscitate, or do not intubate or not. The medical power of attorney will be my number one choice. Okay, I'm not gonna listen to his kids or anyone else. Medical power of attorney. This is a legal document that overrides or trumps anything else. Okay, this is what we call advanced directive. Like in advance, they made a directive to him. Advanced directive may be revoked by the patient at any time if they retain decision-making capacity. Like if they became better at any time, they can cancel it legally also. Okay? Surrogate decision should be based on what the patient would have wanted. Okay? So for example, if a patient is in a coma and they require intubation and his wife is his legally appointed guardian, so if the patient had clearly expressed this, that he would never want to be intubated, but his wife wants him to be intubated, the patient should not be intubated because his clear wishes override those of his wife. Even when we ask the family for surrogate decision making, the answer would be usually what the patient would have wanted if he weren't in a coma or incapacitated. Okay? Hierarchy of a decision making capacity. Like we have an order from the most common to to which one will make the decision if the patient is incapacitated right now. There is always in laws state by state variations, but for the USMLE it is usually something called the next of kin in a specified order. Okay. A mentally competent patient capable of making their own decision. Advanced healthcare directive specified legal instruction from the patient used to guide the medical decision making. Living will is something legal, okay? It is not just a sheet of paper that is written anything. It is a legal document in which individuals describe their wishes regarding their health care to maintain, withhold, or withdraw life-sustaining care should they become incapacitated. And this is something that we should respect equal to the advanced directive, okay? Or the medical power of attorney. Second thing is durable medical power of attorney or healthy care proxy. Okay, admit. Medical power of attorney, we already said it. Healthcare proxy is a legal document through which an individual designed a surrogate to make their specific healthcare decision. So the healthcare proxy is the durable medical power of attorney, and this is your number one choice. Okay. Oral advanced directive. This is an oral statement made by the patient regarding their preference prior to incapacitation. For example, the husband of a patient recall his wife is saying that she would not wish to have long-term tube feeds. Okay, so this is gonna take us to the same point, what the patient would have said or wanted in the same condition. Okay, this is very important. What the patient would have wanted, because it is usually will be the answer. Next of kin, this is after we do not have a living will, we do not have a during medical power of attorney or oral advance directive. We're gonna need a surrogate decision making. We need someone now to take the decision. This is what we call next of kin. Okay, we have his spouse, his other adult child, parent, adult sibling. Who gonna take the decision? Who is having the priority? So his spouse will be the number one or husband. Fiances and non-legal partners are not considered spouses. Okay, so spouse or husband is the first thing. Then adult child, then parent, then adult sibling, then a close friend in approximately 50% of use states. Okay, this is very important because sometimes they ask these questions. Ethics committee or legal counsel, and I do not recommend it for exam taking purposes because it is usually will be the wrong answer. Uh, Waiting room, admit. Okay. Caveats. If the patient's preferences cannot be determined and there is a disagreement regarding the course of action, the wishes of a designated surrogate who is not a family member conflict with the wishes of the family members. What should I do in this? The physician should sit with them all and facilitate a meeting between the disagreeing parties with the aim of reaching an agreement about what the patient would have desired. Okay? I can't stress how important this is because it is usually would be the right answer. No matter what the outcome of the conflict, the wishes of the designated surrogate should always be followed. As I told you, the legal document that is saying this is my advance directive and I want him to take my decision, he will override the spouse or other child or anything. Okay. Oral advance directive may pose problems of interpretation, as oral statements are not as specific or easy to confirm as written statements. So the validity of an oral advance directive increases if the patient has made an informed choice. The instructions were specific and the directive was confirmed by multiple people. Yes, he told us that he doesn't want to be in prolonged oral field, and this is what he said in his oral advance directive. So all the roads are leading to Rome. Okay, okay. Patients with decision-making capacity and competence have the right to provide or withdraw informed consent at any time, even during the procedure. Okay, so this is also correlated with the patient autonomy. So this is a mnemonic to remember the next of kin. A spouseships is a spouse, then C for children, B for parents, and S for siblings. Okay, very important and very high yield to remember it for the USMLE. There are some specific situations like harm to others. A decision to decline treatment may be disregarded if the decision endangers others, like declining treatment for active tuberculosis infection. For another example, let's say a patient came in and they are having HIV and he doesn't want to tell his partner. Okay, I need first to encourage them that you need to tell your partner or partners that you are having HIV or active tuberculosis infection. If they decided that they do not want to tell them and they are not going to tell them, I need to inform their partner, and this is an exception to breaking the confidentiality. Okay, so the special situation when there is harm to others, if the decision to decline treatment may be disregarded if the decision endangers others. Okay, as you already know, active tuberculosis infection is very like it can be easily communicated between others, and he is very dangerous to the community. It's okay if he wants to reject the antibiotics or the treatment of tuberculosis, but I will not make him leave. I need to admit them to the hospital, and if he wanted to decline treatment, he can decline treatment and may not receive it, but they need to be admitted and not leave. Okay? Pregnant patient. A person has the right to refuse certain treatment even if their discussion poses a risk to unborn fetus, like decision of cesarean section. Okay, this is upholds the core ethical principle like autonomy. They can refuse certain treatment if their decision, even if their decision poses a risk to the unborn fetus. How to remember this? Usually in ethics, the fetus, if he's inside his mother, they are considered one person, and his mother can take any decision she wants, even if it can make harm to the fetus, because it is considered a part of her. Okay. For patients with severe mental health disorder, like a psychiatric professional should be integrated into the care team to ensure the core ethical principles are upheld. As I told you, will not be usually the answer. You need first to exclude the other stuff. If there is a changes in the capacity, if a patient with capacity making a decision, it cannot be reversed if the patient become incapacitated unless a designated surrogate waits in to reverse the decision. Okay? This is for the special situations. Um, Now let's move on to medical decision making in pediatrics. What is the pediatric definition? For a minor, we say this patient is a minor if he is less than 18 years of age in most states. The exceptions are Mississippi, which is less than 21 years, Nebraska and Alabama, which is less than 19 years. And you do not need to remember the exceptions, but know that the minor is considered any person in less than 18 years of age. Emancipated minor, it is a minor who fulfills at least one of the following criteria: lives separately from his parents and is financially self-reliant, or is married, or is in duty for armed forces. Okay, a mature minor, like an emancipated minor who is deemed to have the capacity. The status of a mature minor is decided by individual state courts. The exact definition of a mature minor varies by state. So, general, unemancipated minors do not possess a decision-making capacity. The consent for medical procedures or treatment of unemancipated minors is given by the patient surrogate, like parents or caretakers. Okay. However, to preserve the right of autonomy, minors should be involved in medical decision making, like family centered or decision making to the best of their ability. We already talked about informed consent. Emancipated minors are considered to be capable of making decision capacity. Who are the emancipated? Three, live separately or independently, or they are financially self-reliant, married, or in uh, duty on armed forces. Minor, mature minor doctrine, a common law rule that allows mature minors to consent to treatment under certain conditions. The exact conditions are also vary state by state. The minor is an older adolescent, okay? The age varies by state law. Do not worry so much about the variation from state by state because the USMLE exams are usually um, they are choosing something that is already clear, okay? That applies to most of the states. The minor is capable of understanding the information regarding medical procedure and the benefits of the procedures clearly outweigh the risks, and the risks are not very high. So at this things, which is mature minor doctrine, not a very high yield concept, the mature minor can take their own decision. Okay. Uh, we have been now more than 1 hour. We're gonna take legal concept, legal consent, and informed consent, and then we're gonna continue with our discussion and questions in the next session. Okay, let's continue with the legal competence. As I told you, legal competence is something outside of our hands as a physician. This is a legal assessment of a court order. This is a legal assessment of the patient ability to freely make conscious decision, including those regarding of their care. Okay, the term competence refers to decision making in many contexts, not only those related to medical care. Competence is assumed for all adults. As I told you in the start of the meeting, all adults are assumed to be legal competence. Never pick an answer that says this patient is not a legal competence because this is a court order from the government or from the police and stuff like this, not from healthcare aspect. General, it is assessed by a court of law, very important, with input from the patient family and physician as needed. Okay, but as a physician, I cannot emphasize this enough. As a physician, I do not have the capacity to say this patient is legal competent or not. Physicians do not have the authority to pronounce individual legally incompetent. This is what I was saying to you. If an individual is determined legally incompetent, the court will assign a guardian to make decision on their own behalf. Okay. And before I read this note, I want you also to know never pick an answer that says, I'm gonna send them to the court for legal competence assessment. Okay? It will usually be the wrong answer. Guardianship regulates vary state by state, but the preference in assigning guardianship is usually given to the acting power of attorney, a spouse, or other family members. If the court determines that it is not in person best interest to appoint a relative power of attorney as a guardian, a person who shows a special concern for the person may not grant a guardian instead. Okay, this is for clinicians, not important for the USMLE exams. But I want you to know everything that you will not assume that the patients are legally incompetent, and this is determined by a court law. The court may waive the appointment of guardian or grant limited guardianship if there is a durable power of attorney. They are free, the court is free to take their own decision. Under limited guardianship, the guardians may only make decisions in certain domain, like financial, but not a big decisions. A durable power of attorney remains in place even after a person who executed it become incompetent, where the general power of attorney ends after the executor is declared incompetent. As I told you, we have two power of attorneys, a durable and general. The durable power of attorney, as the name implies, it is durable, okay? So if the patient become incompetent, they can take their own decision. But the general power of attorney, it ends after the executor is declared incompetent. And not important for the USMLE, the most important is durable power of attorney. Okay, and this is your number one choice. Questions of legal competence arise in the presence of reduced mental capacity, like very, very severe mental illness, intoxication, impulsive or constantly changing decision, or decisions that are not consistent with the patient values. Okay, legal competence assesses an individual as a globe decision-making capacity relating to financial property or healthcare decision, whereas decision-making capacity is a functional assessment that can vary depending on the situation. For example, if a patient may have capacity to choose between blood pressure medications but not to consent to comply surgery. Last topic for today, informed consent. What is informed consent? It is the process of attaining the patient authorization for a medical test, treatment, or a procedure. This is very important, not only in the United States, but I think there is no medical procedure in the whole world that can be conducted without an informed consent. Okay? The key consideration is to ensure that there is sufficient time before the intervention. We usually do it for elective procedures, like the patient needed to get a hernia procedure, or for the patient to make well-considered decision. A patient with decision-making capacity is free to provide or revoke their consent at any time. It does not to be in writing, okay? This even applies during a procedure, as we already said. Okay. Required components applied to the patient or their surrogate. Okay. No matter who is gonna take the decision. Volunteerness. The decision must be made without coercion. This is for research and for clinical also. The patient is always should have their autonomy. They shouldn't be given money or anything, even manipulating with words. They should be volunteering and with full conscience to make their decision. Capacity, we should assess their decision-making capacity. It must be demonstrated before counseling to the intervention. And comprehension, the decision maker must demonstrate understanding of ramification of the proposed interventions. And disclosure, relevant medical information regarding interventions must be disclosed. I need to tell him every single details about the procedure. Okay, how I should obtain it? Obtaining informed consent. Informed consent should be obtained by healthcare providers like us as physicians. Inform the patients of the benefits. This is very important to remember, guys, okay? The benefits, the risks, and the alternatives and the indications for the intervention of their nature of the illness. And the most important one among these four is the alternatives because they're gonna usually tell you the physician informed the patient about the benefits and risks and the indications and stuff like this. What else is the physician should do? The alternative. The patient should know the alternative to this procedure, okay? This is very important. Let me cancel this. Okay. Alternatives is the most important one, including known complication and estimated risk, like it may lead up to death and morbidity or major bleeding inside the operation. Frequently observed adverse effect and serious risks should be disclosed. Urticaria during blood transfusion and arterial puncture during central venous catheter replacement, respectively. Okay. Alternative intervention, as I told you, this is very important. The expected nature of the disease course without any intervention, if any aspect of the proposed intervention is experimental. Notify the patient about the identity and level of training of each potential participant in the intervention. Who is gonna be the leader? Who is the surgeon who gonna do the procedure? Who are the whole team? Okay, not very important. It doesn't show up in questions, but the patient should know the identity and the level of the training of each potential participant in the intervention. Like who's gonna make it to me? The consultant, the attending, a resident. Okay. Then I'm gonna assess the patient teach decision-making capacity using the teach back method and ability to consent voluntary. Okay. Then I'm gonna document the decision and have the patient sign it as clearly articulated. Use your brain when obtaining informed consent. Brain stands for benefits, risks, alternatives, indications, and nature. Performing an intervention without having an obtained informed consent may legally constitute battery or negligence. Okay, so I always need to inform to get an informed consent, or the patient will have the right that you did like maleficence. Okay, the amount of information shared with the obtained informed consent depends on the frequency and severity of the risk involved. Less information needs to be disclosed for venipuncture. Like you're gonna get a venipuncture. I'm not gonna tell him you're at risk of major bleeding and this, but for cardiac catheterization, it is like a bigger procedure. Okay. Exceptions to the standard informed consent, life-threatening emergency, like unconscious trauma patient without a surrogate patient, if they need to be mechanically intubated right now, or they are dead and need to be resuscitated, I should move on without informed consent. Those 4 points are very important, okay? The patient lacks decision-making capacity, but their surrogate has authorized intervention. So if there is no surrogate or advances directive available, decisions to treat should be made in the best interest of the patient. The patient decided to waive the legal right of informed consent. Like the patient, okay, you have the right to do anything. So they waived the legal right. Disclosing may pose a threat to the patient to affect their decision-making capacity. This is what we call therapeutic privilege. Therapeutic privilege or therapeutic exception. This is an exception to full disclosure in which the physician is allowed to withhold relevant health information from the patient if withholding it is in the patient's best interest. If disclosing it, it would pose serious psychological harm. Like a patient is having a cancer and you're very sick and they we already made sure that from all aspects, but okay. But for in general, any patient should know their diagnosis and anything. And the patient, we already agreed that we should not tell him that the cancer is now under metastasis, and he did not wanted to know. So this is what we call a therapeutic privilege. Okay. Difficulties in obtaining consent should not delay life-saving procedure. This is correlated to the first point that life-threatening emergency. This is a big and very common exception to standardized informed consent. Okay. Uh, we finished the session for today. Hope it was beneficial to you and you learned something. We're gonna continue with our sessions in the next few weeks, months, and days, and we're gonna also move forward to different medical topics along with ethics on different groups. I will share the recording of the meeting, and I will share also on the WhatsApp chat the link of our channel on YouTube and Telegram. Uh, and that's it. Good luck. You're welcome. See you all. Bye bye.